Clostridium, a genus of bacteria known for its distinctive rod shape with swollen ends, often described like drumsticks. These bacteria are fascinating because of their unique structure and how they survive in different environments. Understanding their basic morphology helps us grasp why they're significant in both health and disease contexts. To really understand Clostridium, we need to look at what makes them unique. They're gram-positive, meaning their cell walls have a specific thick structure. The name itself comes from a Greek word meaning little spindle, which hints at their shape. They thrive without oxygen, so they're anaerobic. One key survival trick is their ability to form endospores, letting them endure tough conditions. You'll find them in soil, water, sewage, and even as part of normal body flora. But watch out, they can also cause disease, which is why they're medically important. When identifying Clostridia, a few key features stand out. These are large gram-positive rods, usually between 3 to 8 micrometers long. Most of them can move around, except for Clostridium perfringens, which is non-motile. Interestingly, most Clostridia don't have capsules, again with that exception of C. perfringens. And an important point, they form spores, but only in the environment, not inside infected tissues. These traits help us identify them in the lab. The shape and position of spores in Clostridia are really useful for identifying species. Different species have spores positioned centrally, subterminally, or terminally, and these spores can be oval or spherical. For example, Clostridium bifurmentans has central spores, while Clostridium tetani has spherical spores at the terminal end. Recognizing these differences is key in microbiology because it helps pinpoint exactly which species we're dealing with. Clostridium botulinum's main weapon is its botulinum toxin, a protein exotoxin that's incredibly potent. This toxin is heat-sensitive and can be modified into a toxoid for vaccines. It works by targeting cholinergic nerves, blocking the release of acetylcholine, which leads to paralysis. The toxin's potency is remarkable. Only a tiny lethal dose is needed to cause serious effects. Understanding this mechanism is crucial for both treatment and prevention strategies. The pathogenic process of Clostridium botulinum is quite unique. The bacteria themselves don't invade tissues, but produce a powerful exotoxin. This toxin is ingested or absorbed, then enters the bloodstream. From there, it travels to nerve terminals where it causes flaccid paralysis. This leads to muscle atrophy in affected areas. But over time, neurons can regenerate. This sequence explains why botulism symptoms appear and how recovery can eventually occur. Botulism presents in several clinical forms. Food-borne botulism happens when contaminated food is ingested, with symptoms showing up within 12 to 36 hours. Infant botulism is different. Spores, often from honey, colonize the gut, causing toxico-infection. Then there's wound botulism, where spores contaminate wounds, leading to a longer incubation period. Recognizing these syndromes helps clinicians guide diagnosis and treatment. Diagnosing botulism involves several lab methods. We collect specimens like feces, vomitus, gastric aspirate, food samples, and wound tissue. Culturing these samples involves heating them and growing bacteria on specific media like RCM and blood agar. To confirm toxin presence, tests like the mouse neutralization test, ELISA, and PCR are used. Microscopy with gram staining also supports diagnosis. Together, these methods provide a thorough approach to identifying botulism. Coming to Clostridium tetani. Tetanus virulence mainly comes from two toxins. Tetanospasmin is a neurotoxin acting on the central nervous system by blocking inhibitory neurotransmitters, leading to continuous muscle spasms and paralysis. Tetanolysin is a hemolysin, contributing to tissue damage. This mechanism explains the severe muscle rigidity and spasms characteristic of tetanus, highlighting why early treatment is vital to prevent complications. Tetanus manifests in several clinical forms. Generalized tetanus features lockjaw, a sardonic smile called rhesus sardonicus, severe muscle spasms like opisthotonus, and can lead to respiratory paralysis. Neonatal tetanus, often linked to umbilical cord care, carries a high mortality rate. Localized tetanus involves muscle spasms confined to a specific area. Understanding these syndromes helps clinicians recognize and manage tetanus effectively. The clinical signs of tetanus are striking. Lockjaw makes it hard to close the mouth due to muscle spasms. The sardonic smile results from sustained facial muscle contractions. Opisthotonus is a severe arching of the body caused by intense spasms. These symptoms reflect the toxin's effect on the nervous system and show just how debilitating tetanus can be. Recognizing these signs early is crucial for timely intervention. Diagnosing tetanus involves several steps. Collecting excised tissue samples is preferred over swabs for better accuracy. Cultures are grown on blood agar and RCM media. A key diagnostic test is observing death in unprotected mice, indicating tetanus presence. Mouse neutralization tests confirm toxin production. However, gram staining isn't reliable here. This process ensures accurate diagnosis, guiding appropriate treatment. Treating tetanus requires a multi-pronged approach. Antitoxin therapy neutralizes unbound toxins to prevent further damage. Supportive care manages complications like respiratory failure. Proper wound care stops ongoing toxin production. Antibiotics eliminate bacteria producing the toxin. Finally, active immunization helps the body build its own defense. Together, these strategies improve patient outcomes significantly. Clostridium perfringens, another important medically relevant bacteria, produces several toxins with distinct effects. The alpha toxin targets red blood cells, platelets, white cells, and endothelial cells, causing widespread damage. The beta toxin leads to necrotizing enteritis, a severe intestinal condition. Epsilon toxin increases vascular permeability, worsening tissue injury. Iota toxin causes necrotic lesions and also affects blood vessels. Enterotoxin and minor toxins contribute to the disease process. Knowing these helps us understand the severity and variety of infections caused by Clostridium perfringens. Clostridium perfringens infections develop through different mechanisms. Cellulitis involves minimal toxin production without muscle invasion. Fasciitis, or suppurative myositis, includes muscle involvement and pus formation. Gas gangrene is a severe, rapidly spreading infection that can be life-threatening. Food poisoning results from consuming contaminated food. Necrotizing enteritis causes severe intestinal tissue death. Septicemia is a dangerous bloodstream infection. Each type varies in severity and clinical management. Diagnosing and treating gas gangrene requires specific tests and interventions. Labs findings include abundant gram-positive bacilli without spores and smears. Naegler's reaction and the reverse Camp test help confirm diagnosis. The stormy clot reaction in litmus milk is another clue. Treatment involves surgical removal of infected tissue and hyperbaric oxygen therapy to inhibit bacterial growth. Images show how antitoxin can suppress bacterial growth and the results of confirmatory tests, reinforcing these approaches. And finally, Clostridium difficile. Its virulence factors are key to its pathogenesis. It produces oval terminal spores and is motile. Its toxin A acts as an enterotoxin, causing diarrhea, while toxin B is a potent cytotoxin that damages cells. These toxins explain the symptoms and severity of infections caused by Clostridium difficile, especially in healthcare settings where antibiotic use disrupts normal flora. Clostridium difficile is part of the normal gut flora, but can cause serious disease under certain conditions. It's associated with pseudomembranous colitis, which causes abdominal cramps and diarrhea, often linked to antibiotic use like ampicillin and erythromycin. It's also a major cause of antibiotic-associated diarrhea. Understanding this pathogenesis helps us manage and prevent these infections effectively.